basically it's the same principles. We're still asking what can we do for this emergency patient to enable them to be a day case? Do we need to admit them preoperatively for their investigations? Traditionally, emergency patients, they come in and they wait a couple of days for their ultrasound scan and their bloods to come back, and then someone scratches their head and then we make a plan, and then, yes, it is cholecystitis, and then they sit and wait 3 days for a slot to come up on the emergency list. So do we need to admit them for that? Is the procedure appropriate for day surgery? Can we develop an ambulatory pathway? Now, we know what the day surgery definition is. It's selected patients for a planned procedure returning home on the same day. But emergency patients are definitely unselected, they're definitely unplanned, and they can turn up any time of the day or night. So the international definition for emergency day surgery is to try and avoid overnight stay following their surgical procedure. So it may not be that we can manage the whole pathway as a day case, but once we get them to theatre, can we then discharge them that day? There are examples, however, where we can manage the whole pathway as a day case, and I'm going to show you different ways of managing it. If we look at surgical urgency, elective, we've spent most of the day talking about. Immediate, life-saving, got to be taken to theatre within minutes. They're not going to be a day case. Urgent, really acute deterioration of a condition. Again, they may or may not, but they're less likely to be day cases. And we're really looking at your expedited patients, patients who require early treatment, but their condition isn't an immediate threat to life. And these are the procedures that people are looking at now as doing as day case that are emergencies. Incisions and drainage of abscesses we've been doing for some years, but we're now talking about appendixes, hot gallbladders, hernias, and then in trauma and orthopaedics, your emergency arthroscopies, K-wirings, and your gynae diagnostic laparoscopies, EVACs, a significant number of the ectopics, the non-unstable ectopics. And we've got 3 different pathways for emergency day surgery. You've got true emergency day surgery, so a patient comes in, has a diagnosis, has an operation, gets home on the same day. You've got day surgery on the emergency pathway, so they may be in for a day or so having their diagnosis, but then they have their surgery and go home. And then you've got planned emergency day surgery, where they present to A&E or through the surgical hot clinic and can be sent home and brought in the next day or a couple of days later for their emergency surgery. And these are the different pathways that we look at. The true ambulatory surgery, the yellow on the left, everything's done on the same day. Day of surgery discharge, yes, the first few bits might be as an inpatient, but once you get them to surgery, they go home on the same day. And the planned emergency, you've got your diagnosis and then you readmit, you have your operation and your discharge on the same day. And if we look at it the other way round, your true emergency surgery, you really want to complete the pathway on one calendar day. But your emergency pathway, then you might send them home and bring them in. I was going to talk about the abscess pathway, because this is something we've been doing for many years now in Torbay, and I think it's a model that you could learn from and adapt for other procedures. So you identify an emergency minor procedure, surgeons see them, send them home with fasting procedures instructions, they're given a time to come back, they get the slot for theatre, the procedure occurs and they're sent straight home. These patients used to sit in hospital beds for days because they were never a priority. They were always bumped off the end of an emergency list, and the poor so-and-so sat there with really sore bums for about 3 days waiting for someone to do a 5-minute procedure on them. So in Torbay, we developed an abscess pathway about 15 years ago. We identified that these patients weren't prioritised, that they waited starved all day, they were always being bumped, and also that we had time at the beginning of an emergency list that was wasted. I don't know how many of you actually get your emergency first patient to theatre at 8 o'clock, but we weren't. So we decided we were going to schedule these patients for 8 o'clock on the emergency list and manage them via a semi-elective pathway. What we did was they were sent home from A&E, they were brought into the day surgery unit at 7:30 in the morning, and at 8 o'clock the deal was if there was a day surgery abscess to do, they were sent for. not negotiable. As long as there wasn't something life or death on the table, they were sent for. Surgeon's handover at 8:30. The patient was in the anaesthetic room waiting to be anaesthetised. As soon as we saw the white of the surgeon's eyes, we pressed go on the propofol pump. Surgeon came in and scrubbed. It's all done and dusted by 9 o'clock. And this is the outcome. So we published this 10 years ago or so now, and basically showed that with our traditional pathway, the total length of stay for these patients was 35 hours, and now it's 6. Huge difference pre and post-operatively, 5.7 times reduction. But this one's interesting as well. So the blue line is what time the emergency theatre used to start, and the red line is when we've got abscess patients coming through, what time we start. So we've shifted our day. We get these patients done when nothing else was happening anyway. And this just shows you the procedures that we do under that pathway. It's all what you would expect, lumps and bumps. And our day case rates over the years, so now 60% of the abscesses are done through this pathway as a day case. Evacs, we do these a slightly different way. So these are the retained products of conception, patients who are having miscarriages. Traditionally, these patients were brought into a gynae ward and again sat there for days crying because they just lost their baby, and it was miserable. So they come to the early pregnancy unit, decided they go to theatre, and they are put onto one of our elective gynae day surgery lists. So we don't do these through the emergency theatre. Our surgeons have all agreed that all their lists can have one evac added, because an evac takes 10 minutes. So they're put first on the gynae list. We have 4 gynae lists a week, and it absorbs most of the activity. They come to pre-assessment, they're admitted to the day unit, they have their operation, they're sent home, they have a follow-up phone call the next day. There's still a few that have to go through the emergency pathway, particularly at weekends if we don't have day surgery lists and they can't wait till Monday, in which case they do go through the emergency theatre, but it's not many. 70% or so now go through the day surgery unit, and it has to be better for these women than the pathway we used to have. So finally, true emergency surgery. The key thing here is, can we be a bit more timely and can we optimise these patients and get them to theatre? But we've got to have access to an operating theatre, and again, they're sometimes the low priorities. The appendixes, the lap choles, and a sick laparotomy comes in, and an aneurysm comes in, and. So can we manage a day surgery pathway for these patients? What we did in Torbay was we recognised that we had busy emergency lists and we had these patients that were just not being prioritised. And we had a brainwave. It was February half term, and a lot of our elective day surgery lists had gone down. So we suddenly realised we had these empty day surgery theatres. The staff were getting fed up because they were being reallocated here, there and everywhere. And they were ripe for the picking. So we had this idea, well, let's see if there's any emergencies that we can grab, bring them down to day surgery and send them home. What could be easier? So we've identified procedures, lap choles, appendixes, hand traumas, mandibles, suturing of kids who've fallen over and got facial lacerations. And we even did, this was our star patient, a torsion of testes who turned up in A&E. The surgeons phoned us, said, have you got emergency day surgery list this morning? Yes, we have. We went and got him from A&E, brought him to the day surgery unit. He was home 3 hours later, literally through out the door. So how have we set this up? What we've done now is we identify the week before any empty day surgery lists and we badge them as day surgery emergencies. When the surgeons book patients onto the emergency lists, they tick a box to say, yes, this would be appropriate for day surgery. And so at 8 o'clock in the morning, when we have our emergency handover, we say, have we got an emergency day surgery list today? Yes, we have. Are there any patients we could move down to that theatre? Yes, there are. And in 10 months, we've treated 185 patients. We've saved 218 hours of inpatient theatre time. 68% of them have been discharged as day cases, and we've saved 204 bed days, which we equate to about £45,000. So we're really chuffed with that pathway, and it was something that almost happened by chance, by us just thinking, oh, what could we do with this? So I'm going to finish there and hopefully leave us a bit of time for chatting. We have analgesic packs in A&E that the A&E staff discharge them with, and it's paracetamol, ibuprofen and oral morphine. So they're sent home overnight with some doses of oral morphine to take as required. In actual fact, the percentage of patients who needed more than a single dose of oral morph was very low. But yeah, we do give them that additional analgesia to tide them over the night.